At this time, I'd like to bring up Dr. James Law, who is director of our clinical core and the person responsible for most of you being here because he put me on this path. Dr. Law is a graduate of Duke University and finished Emory University for his residency in neurology. He does a whole lot of things, but the most important thing you need to remember is that he directs the clinical core and directs the research here. Jim.
Thank you, Monica. Good morning, everybody. Thank you for coming. So I think I sent slides early enough to get them up, but I know some of you have been here before and some of you have heard me talk before, so if I tell one or two jokes that you've already heard, don't give away the punchlines, okay? And so what I'm going to do is I'm going to start off and get the bad news out of the way first. So if any of you are holding a whole lot of Biogen stock before this spring, I'm so sorry. So back in last month, Biogen stock took its biggest one-day tumble in the history of the company. I think it dropped 30% in one day. And that was because, yet again, another Alzheimer's clinical trial failed. So bad news. We were very disappointed. It was a drug called aducanumab, which there had been some very promising results with from earlier phase studies. But the analysis midway through indicated that drug was not going to prove to be successful in slowing the course of Alzheimer's disease. So I grew up a Browns fan, and I made this slide over a couple of years ago when they couldn't win a damn game. But now, you know, they're going to be contending. They're going to maybe be in the playoffs next year. And we're still shooting blanks. So Dr. Parker said that we have no effective cures or truly effective treatments. Some of those medications can be helpful that we have, but we really don't have what we need. But I'm going to tell you, I'm still optimistic despite all the failures that we've had to deal with, and I want to explain to you over the course of the next few minutes why I'm still optimistic. This is an updated slide indicating just the magnitude of this problem. So currently, worldwide, there are close to 50 million individuals suffering from some type of dementia. And without more effective treatments, it's going to continue to be a big problem. And even worse, it's going to be a bigger problem in countries and places that can least afford to deal with the problem. So you see that the projected growth in high-income countries like the US is significant, but it's twice as high in areas in the developing world, in lower and middle-income countries. So this is a global problem. And it's one that we have to fix. We cannot not fix this. We have to overcome this problem. It already consumes 1% of the domestic product of the entire world. So $1 in every 100 that's generated worldwide is spent currently dealing with this dementia epidemic. And Dr. Parker talked about dementia, and it's a progressive disorder, and I want to show you this slide. This is just a graphical representation of what we see happening in people who are suffering from dementing illnesses. And it's really that late stage of disease that I've circled in red when there's a more profound loss of abilities, a loss of quality of life. That's really the scary part of these illnesses. Earlier on, in earlier stages of symptoms, in mild dementia, during mild dementia phases, or in the very mildest clinically detectable phase, that mild cognitive impairment phase, whatever the underlying cause of the dementia, they tend to progress slowly over time, and the earlier phases of it are really not so horrifying. I mean, they're not fun. You know, if you can't remember stuff, it's kind of annoying, but you can still, at those early stages, maintain an excellent quality of life. We have patients that we take care of with mild cognitive impairment who are continuing to function, run companies, practice law, practice medicine, unless they're my surgeon, in which case I tell them to retire right away. But at early stages, they can still function at a very high level. And so I just want you to remember that when we say dementia, it's not somebody who's soiling themselves. It's a progression, so there may be mild symptoms, and it's really the late stages of disease that's really horrifying. And as Dr. Parker mentioned, there are many different causes of dementia, and Alzheimer's disease just happens to be the most common, but there are many others. And one of the things that will happen in the coming years is you can't treat all dementias the same way. Depending on what's causing the dementia, you're going to have to use different treatments and different approaches to manage those diseases. And yet, this remains a difficult concept for people. What is dementia? What is Alzheimer's disease? So I created this slide to explain the difference between Alzheimer's and dementia. So saying that somebody has dementia is kind of like saying, I have a headache. But you might have a headache because you have an aneurysm that's about to rupture, and that's a very specific reason for a headache. Or you might have a headache because you're Tiger Woods when he was younger, and his wife was taking a 7-iron upside his head. I was happy to see Tiger make a comeback this year, and we're happy to see that. It sounds like he's really got his life back together, and we're proud to see him do that. But those are two very different reasons for having a headache. And so if you have an aneurysm or if you've got a 7-iron upside your head, the treatments for those things are very different. And the causes for the headache is very different. And so when we say somebody has dementia, we're talking about the symptoms of dementia, the loss of memory and other thinking abilities that progresses over time and erodes your quality of life and your abilities. And that's just a description of symptoms. Just like when we say somebody has mild cognitive impairment or memory loss, those are just descriptions of symptoms, but it doesn't tell you what the underlying cause is. Alzheimer's disease is a very specific disease. This is a famous photograph of Frau Auguste Dieter, who was the first patient that Alois Alzheimer studied, both during life and after her death. And the unique thing about her, and the reason that this became such a famous case, was not because memory loss and cognitive decline had been unknown. Age-associated cognitive decline has been known since antiquity. But Frau Dieter, however, was brought to the hospital at the ripe young age of 51 because she had already been suffering pretty significant dementia symptoms, wasn't able to care for herself or her family, and so her husband brought her to the hospital because he couldn't manage her at home. And we now know that, in fact, Frau Dieter, just as a sidelight, actually had a rare genetic mutation that caused early onset Alzheimer's disease. And so these are mutations that we know of that helped us a lot in terms of understanding Alzheimer's disease since the early and mid-90s, and she actually was a mutation carrier. But after her death, Alois Alzheimer studied her brain and described the same pathological hallmarks that we still think about today. And in the middle of this picture is something called an amyloid plaque, or a senile plaque made up of this amyloid beta protein. And then those darker areas that are pointed out with the arrows, those are brain cells that have abnormal accumulations of a protein called tau. And those two features, the abnormal accumulation of amyloid and the abnormal accumulation of tau in the brain cells, is seen in every single individual who has Alzheimer's disease. If you had a dementia because of some other cause, if you had a dementia because of Lewy body dementia or frontotemporal dementia, you don't have these same changes in your brain. This is very specific to Alzheimer's disease. And those proteins, Dr. Parker mentioned spinal taps. We don't actually do spinal taps on everybody. It's not like I walk around with needles in my pocket. Not every day. But because the brain is a very special organ, so it's not directly accessible in the same way that your liver is or your kidney is, because there's something called the blood-brain barrier that keeps the brain somewhat separated from the rest of the body. But the spinal fluid is actually bathing, it's made inside your brain, and it surrounds the brain and spinal cord. It acts as a bit of a shock absorber. It does a lot of other things, but it's in direct contact with the brain. And what we learned a number of years ago is by collecting some of that fluid, we can actually measure those amyloid and tau proteins directly in the spinal fluid. And that helps us to understand what's going on, because people used to say that you couldn't be sure somebody had Alzheimer's disease until after they were dead and you look at their brain under a microscope. Like, I don't really care too much at that point, but if you can tell me what's going on in my brain before I die, that may be of more use. And so we do the spinal taps a lot. And who's had a spinal tap in the audience? Look at that. I love this crowd. Wait, me too. I've had it done twice. That's my butt poking out of the right side of this picture. And my friend collecting spinal fluid from me, and I've done that twice. And first time I did it just because I was telling everybody it didn't hurt, and I figured, well, I ought to check and see if I'm lying or not. I only screamed a little bit. But it's a very simple procedure. It's very safe. We collect the fluid several inches below the end of the spinal cord, so there's zero chance of hitting the spinal cord. But by measuring the proteins, the amyloid protein and the tau protein in that spinal fluid, we can infer what pathologies are present or not present. It may be that, the fluid does not show those abnormal proteins, and that helps us to understand what's going on inside the brain. Now, we mentioned mild cognitive impairment a couple of times, and again, that's just a description of symptoms, right? So it's not a disease. It doesn't necessarily imply a specific cause for the cognitive impairment or memory loss. What this scatter plot shows is in the red is a pattern of spinal fluid, amyloid, and tau that's typical of what we see in individuals who have Alzheimer's disease. And what's in the green are normal levels of the amyloid and tau protein in the spinal fluid. And so by measuring these proteins in somebody who has mild cognitive impairment, I can tell whether that mild cognitive impairment is being caused by Alzheimer's disease or not. The changes in the brain causing those mild symptoms may be related to Alzheimer's disease, or it may not. And here's where that becomes very important. So if I do that spinal fluid test in 100 people who have mild cognitive impairment, and then I separate them at the time that I do the spinal fluid based on whether or not they have spinal fluid, amyloid, and tau that looks like Alzheimer's disease or doesn't look like Alzheimer's disease, is normal. The memory loss is the same, irrespective of what the spinal fluid looks like. But if you have a spinal fluid profile, when you have mild problems, memory loss, you have a spinal fluid profile that looks like Alzheimer's disease, over the course of the next 5 years, there's virtually a 100% chance of that getting worse. The flip side of that is if I see some, what'd I break? The flip side of that is if I do that spinal fluid test in somebody who has mild cognitive impairment and their spinal fluid is normal, the probability of them progressing to mild Alzheimer's disease and dementia getting worse in the course of the next 5 years is less than 10%. So this is why we do spinal fluid tests so frequently, because it has a hugely important prognostic, predictive value in people who have very mild symptoms. Because if you know that over the course of the next 5 years you're likely to decline from your mild symptoms currently to more severe symptoms, you're going to want to take care of things and make plans and discuss with your family, do all the things sort of in anticipation while you do everything you can to slow down the progression of the disease. On the other hand, if you know that your probability of getting worse in the next 5 years is very, very low, you go out and have a celebratory dinner. Now, I want to just spend a couple of slides talking about something that's been near and dear to our hearts in the Goizueta Alzheimer's Disease Research Center, and part of the driving motivation for the partnership that Dr. Parker and I and others in the Alzheimer's Center have had for over a decade now. This slide this is actually a dated slide, but this is referring to something called the Alzheimer's Disease Neuroimaging Initiative, ADNI. And it's ongoing. In fact, I think there's a booth recruiting for ADNI 3 right now here today. But this is perhaps one of the most important observational studies ever conducted in Alzheimer's research. And it's really based on the results of this study that we decide what spinal fluid profile looks abnormal and what looks normal, right? So you have to have some foundation for saying, well, this is an abnormal finding, this is a normal finding. And ADNI largely drove that, and that has translated into clinical practice. And here's the problem. The findings from ADNI and many of the other studies that have driven what we've decided is normal or not normal is based overwhelmingly on Europeans and European Americans, Caucasians. And the proportion of people of color, Dr. Parker's gotten me accustomed to that term. I've never really liked it, but I say it now. I guess it's the correct thing. The proportion of non-Caucasians who contributed data to this is tiny. And so that means when I do that test in my clinic and I get a result, and my patient is a white person, I know that the results are valid for them. If they're Asian or Hispanic or black or whatever other colors we've got, if you're Native American, we don't have data to tell us what is normal, what is not normal. So it's an enormous gap in our current knowledge base, and this is something that we've been focused on addressing for the better part of 10 years now. And because of the engagement with our communities, we've made tremendous headway. So I created this bar graph just to show you what things look like over the last 15 years. And back in the mid-2000s, during that 5-year period, I looked at what the racial makeup, race and gender makeup of our research participants was in the Alzheimer's Center. And you can see it was overwhelmingly Caucasian. 46 or 7% Caucasian women, 37% Caucasian men, 13% African American women, and I don't know, what is that, 3% black men. And we made a concerted effort, and we decided we were going to do something about that here because we're in Atlanta and we're in a unique place and position to address this problem. And you can see what's happened in the last 5 years. There are the largest group of folks in our research registry right now in the Alzheimer's Center is African American women. So we've done great. We're making some headway, but you can see there's one bar there that's shrimpy compared to all the rest of the bars, and you know who you are. So, but we've made excellent headway. So this is something that we're very proud of. I think that we all should be proud of what we've done here. This is not something that's easy to do, and the Emory Alzheimer's Center is really the envy of the entire network in terms of our success here. So let me show you a different way of looking at Alzheimer's disease in living people. So this is now an MRI scan, and the colors, the yellow and red colors, represent areas where we know there's Alzheimer's pathology. So we can do this using specialized scans and see the presence of that pathology in people before they die. And so those two pictures on the left represent individuals with Alzheimer's disease symptoms who have differing levels of the Alzheimer's pathology. This is the amyloid pathology, whereas the picture on the upper right is an individual who's cognitively normal, has no memory problems, and has no Alzheimer's pathology. This is also somebody who's cognitively normal, has no memory symptoms, and is functioning perfectly fine, and they have a significant amount of Alzheimer's pathology already present in their brain. Weird, right? Not so weird. Anybody have heart disease? Good, this is a healthy crowd. Nobody with heart disease. Folks who have heart disease, and I think we all understand this pretty well, don't develop blockages overnight. And Elizabeth, it's the big one. That doesn't happen overnight. That happened over a period of many, many years as you ate all that fried chicken and didn't take care of yourself, didn't exercise, or had bad genetics. It's not always your fault, those of you who had heart disease. What happens is gradually there's an increased blockage that develops in the coronary arteries. 1 minute! Coronary arteries that eventually may lead to heart attack. We now understand that Alzheimer's disease is no less a chronic condition. The pathology of Alzheimer's disease is probably evolving for 15 to 20 years before somebody's diagnosed with Alzheimer's disease based on clinical symptoms. So that pathology is building while you're continuing to function completely normally for many years before you develop the symptoms of Alzheimer's disease. So this is a major challenge that we currently face, is we can detect the presence of that pathology in healthy people. So that same spinal fluid could be done, or that PET scan can be done to detect the presence of pathology, but it doesn't tell us where you are in that course. It doesn't tell us if you're going to develop symptoms in 5 years, 10 years, 15 years, or never. Lots of people die with pathology who never have symptoms of the disease. So let me just get to, so the bottom line is we need, in order to have an effective intervention, we have to start early and do prevention. And we're actually in late stages of evaluating a prevention trial. By mid-2021, we should get results from a large prevention trial to see if, in fact, the treatments can delay the development of Alzheimer's disease. I'm going to have to skip these, but let me just tell you where we're going here in terms of preventing disease. So I told you that the scary part of disease, whether it's Alzheimer's or something else, is here in those later stages. The cure for Alzheimer's disease is going to come from these interventions that allow us to prevent, delay, and slow the progression of disease, because ain't nobody getting out of this alive. You're going to die from something. You're going to get run over by a bus. You're going to drop dead of a heart attack. But the point is, if we can delay and slow the progression sufficiently that you never get to those late stages of disease, then we've done our jobs. And that cure, I promise you, is coming. We're not far from it. I think we're going to start to see effective treatments very soon. And during my lifetime, I expect to see us to be doing prevention. So thank you very much.
Okay, stay there, Jim. We took a couple of minutes. We've got 5 minutes for questions. So we're taking your questions. If you have a piece of paper and you have a question, please hold it up so one of our hostesses can forward them to the front. You only got 5 minutes. Ms. Mary's about to throw me a sign, so 7? We got 7?
Oh, sure, you give her 7.
No, it's us. It's us. It's us.
So the question is whether there's a correlation between MS and early Alzheimer's disease. No. Multiple sclerosis can cause its own cognitive problems, but just like I was saying, it's a very different underlying pathology and physiology. So they're both important diseases, but not directly related to one another. Where is this spinal fluid? So the question is where that spinal fluid originates. And it's actually made in special tissues inside your brain, and it's made at a rate of about 15 to 20 milliliters an hour. So the entire volume of your spinal fluid is actually turned over virtually every day. And we don't. And there's another question about the role nutrition might play on the spinal fluid, and we don't know a whole lot about that at this point. So this is a really good question. There's very little or no follow-up following diagnosis of mild cognitive impairment, and why. And here's another question about symptoms of mild cognitive impairment. So mild cognitive impairment, the most common form of it that we see is a decline in memory, which is an abnormal decline in memory. So usually we require testing to determine whether somebody has mild cognitive impairment. So You know, I was at a meeting about a year ago. This just drove me crazy. But I was sitting across the table from a guy I've worked with 15 years, and I could not think of his name. That happens. You know, just like we all wanted to slap our eye doctor the day he told us that we needed reading glasses. Some of these things happen. But when we talk about somebody who has mild cognitive impairment, it's not normal age-related changes. And we usually can tell that by administering some paper and pencil tests and determining how you're performing across those tests. So it's a little bit more complicated to diagnose at very early stages. And the question about follow-up for mild cognitive impairment, there should be follow-up. You know, for clinical follow-up, most of the time we're monitoring symptoms. There are no FDA-approved treatments for mild cognitive impairment. If we know that the mild cognitive impairment is likely to progress to mild dementia and Alzheimer's disease, we'll often start treatments. But there's a new program that's just getting started, something called the Mild Cognitive Impairment Empowerment Program, MCI Empowerment Program. And that program is designed to work specifically with folks with mild cognitive impairment to come up with better tools for understanding their function, their dysfunction, the areas where they have trouble, applying non-pharmacologic methods to try and help sustain their independent functioning. So more to come. You're going to hear a lot more about the MCI Empowerment Program probably next year.
Brain injury, traumatic brain injury.
So the relationship between traumatic brain injury and dementia. So because the time boss, brain injury causes a traumatic brain injury causes changes in the brain that are complex. And there is a relationship epidemiologically between traumatic brain injury and Alzheimer's disease. And we just don't fully understand it yet. The things that you hear about, the CTE, the chronic traumatic encephalopathy, the thing we worry about with football players, that pathology is different and distinct. And the overlap between that and Alzheimer's disease is still being worked out.
This is about lumbar puncture and research, and do you get the results?
That, again, the results, so the question about getting results of the lumbar puncture. So this is 3 whole minutes? I'm talking fast for nothing. The spinal fluid testing is tricky. So I will not infrequently have people come to see me in clinic for a regular clinical encounter and say, you know, my mom had Alzheimer's disease. You know, I'm close to the age she was when she developed symptoms. I want to know if I have Alzheimer's disease. Can you do that test? And my answer is no. I won't do it. You can't make me. And the reason for that is that if I get a negative result and you have no Alzheimer's pathology, you're 60 and you have no Alzheimer's pathology in your brain, that's great. If I knew that that was the result I was going to get, I would say yes and do it every single time. Because that's good news. That means that your likelihood of developing Alzheimer's disease over the next decade or two is extremely low. The flip side of that, however, and this is an area that we're studying intensively, this is probably one of the largest areas of focus right now in our research activities, and that is coming up with a prediction. So if you're normal, and you're 65 years old, you're not having any problems, you're working, you're doing everything you want to be doing, and you have a positive test, what does that mean? I don't know. And so until we do know, until that result becomes clinically actionable, giving that result is very complicated. Some people just want to know. I don't care if you can't predict what's going to happen. I want to know whether I have the disease pathology or not. From a research standpoint, it raises some serious ethical questions because I feel very strongly that you should have access to every piece of data that we get from you, whether it's cognitive testing, whether it's spinal fluid test results, whether it's ApoE genetic testing results. I feel like we ought to be disclosing that information, but we need to do it in an ethically responsible way, because if I tell somebody you have a positive spinal fluid test and they go jump off a bridge tomorrow because they've misinterpreted the meaning of that test result, I've done something terrible. So this is actually something that I've just initiated a discussion with folks in the Emory Center for Ethics to put together an advisory group of research participants to help us figure out the best way to disclose that information, to disclose the results of spinal fluid and genetic testing that we may be doing on a research basis, but make sure that people have access to the right education to go with that data. And I obey and shut up now.
Thank you, Dr. Law. He canceled his morning clinic so he could be here.